Hello, this is Michael Altos, and we are finishing up our discussion on psychiatric and central nervous system drugs. This is part 3. So now we're going to talk about anti-epileptic drugs. And the first thing I want to point out is, in case of an emergency, if a patient is having a seizure in front of you, the fastest drugs that will stop the seizure right there and then are barbiturates, benzodiazepines, and propofol. Now, you can imagine there may be situations where a bolus of propofol is more or less appropriate, and so you have to decide the acuity of the situation, whether the seizure is stopping on its own or not, and what your resources are before you administer any of these drugs. But these are the 3 drugs that can stop a seizure most commonly right there and then in its tracks. Having said that, we're going to first talk about now some of the other anti-seizure drugs, and we'll start with phenytoin, also known as Dilantin. Phenytoin blocks sodium channels. It actually blocks a lot of different channels. It blocks calcium and NMDA channels, but primarily it blocks sodium channels, and that's important for us to know and remember. Phenytoin is a very, very protein-bound drug, so you have to be cautious in certain situations when patients are taking phenytoin. First of all, if someone is malnourished and has low albumin levels, then they'll have a lot more free phenytoin, and we'll see that can be dangerous. It's important to know that phenytoin levels can be checked with a serum phenytoin level that's sent to the lab. A normal therapeutic level is between 10 and 20. And there are drugs that can increase or decrease phenytoin levels in a patient who's otherwise been stable. So we should be careful anytime we introduce new drugs into a patient who's taking phenytoin. This is very important. Phenytoin is a good example of a drug that is metabolized with zero-order kinetics at high plasma levels. And we talked about this in the very first lecture of last semester, that a lot of drugs have first-order kinetics, but they flatten out to zero-order kinetics at high plasma levels. And phenytoin is an example of that drug. The side effects of phenytoin include of course, central nervous system effects. You can get nystagmus, which is a beating of the eyeballs to the side or up and down, ataxia, which is a kind of imbalance, and nausea and vomiting. Phenytoin is also a teratogen, so it should not be given to pregnant patients. The loading dose of phenytoin is 10 to 20 milligrams per kilogram. I usually give people 1,000 milligrams when I need to load them with phenytoin for your typical adult. Patients who are taking phenytoin, and we'll see this again with Keppra, may need higher doses of neuromuscular blocking agents. These patients chew through their rocuronium very quickly. Phenytoin needs to be given very slowly, less than 50 milligrams a minute. So you can see to give 1,000 milligrams is going to take a good 20 minutes, which is why phenytoin is probably not the best drug to stop a seizure right now, because it takes a while to get the whole dose in. Phenytoin also precipitates in IV lines into a thick, white, chalky substance. So it can precipitate in IV lines or in catheters, so be sure not to mix it with any other drugs. There is a drug called fosphenytoin, or Dilantin, and it's a prodrug. So you give that drug and then it gets converted to phenytoin in the body. And this allows you to give it more quickly and less hypotension, but at least at our institution, that drug has not been available for a little while due to some sort of shortage. The other common anti-epileptic drug we're going to discuss today is levetiracetam, also known as Keppra. This drug is usually given 500 to 1,500 milligrams. It can be given IV or PO. The dose is the same. The mechanism of action is not fully understood, and really there's surprisingly little that we need to know about this drug because its side effects are pretty minimal. There isn't a lot of hepatic metabolism. There's not much protein binding. And the only thing to be aware of is you may need to decrease dosing in renal disease because it is renally excreted. Once again, patients taking Keppra will also go through their neuromuscular blocking drug much more quickly than patients who are not taking Keppra. Before we leave anti-epileptic drugs, I just want to discuss gabapentin, also known as Neurontin. This was developed as an anti-epileptic drug, but in fact, it's not really used for the treatment of epilepsy very much anymore. It's really used to treat pain, chronic neuropathic pain, diabetic pain, and things like that. patients may take multiple daily doses. And often when these patients stop their drugs, they get tremendous, burning or lancinating pain in their extremities or in the site of their chronic pain syndrome. And often that pain isn't really treated very well with fentanyl or Dilaudid. So for the most part, I encourage these patients to stay on their gabapentin in the perioperative period. There isn't a whole lot else to say about gabapentin in the scope of this lecture. Take a moment to consider any questions you may have, and then we will move on to the next section. So now we're going to speak for a few minutes about Parkinson's disease. This is a degenerative disease of the central nervous system where patients have symptoms like tremor, rigid muscles, and slow movements, and they develop almost like microscopic movements. They also have severe autonomic dysfunction, they become demented, and all of this is due to a lesion in a part of the brain called the substantia nigra, which creates dopamine. So these people have a dopamine deficiency. So the treatment then for Parkinson's should be to give them dopamine. And that's what we do. We actually give them a drug called Levodopa, or Sinemet, which is a precursor to dopamine. Why don't we just give them dopamine? Because dopamine does not cross the blood-brain barrier. But Levodopa can cross the blood-brain barrier. Once it crosses the blood-brain barrier, an enzyme called dopa decarboxylase will convert it to dopamine. Now you may wonder, what prevents it from getting converted to dopamine before it crosses the blood-brain barrier? And the answer is we give Levodopa together with a drug called carbidopa. And carbidopa prevents the Levodopa from being decarboxylated until it crosses the blood-brain barrier, because guess what? Carbidopa does not cross the blood-brain barrier. What are the side effects of Levodopa? Well, orthostatic hypotension is pretty common. You might expect otherwise since we're giving them dopamine, but this is what we see clinically. And these patients should not abruptly stop taking their Levodopa. When that happens, they can develop Parkinsonian symptoms, of course. They can sometimes develop neuroleptic malignant syndrome as well. Now, this drug is often taken 3 or 4 times a day, and I've learned the hard way that you should ask all of these patients, when was your last dose, and what happens if you miss a dose? Because if this patient gets bad symptoms, Parkinsonian symptoms, when they miss a dose or two and they're going to have a long surgery, you need to be prepared to give some doses in the operating room, which might have to go in through an NG tube, because these drugs can't really be given IV. Now, we talked before about the antipsychotic medications, which bind to the dopamine receptor. And as you can imagine, that would be the worst thing you could do to a patient with Parkinson's disease who already has a deficiency of dopamine. So haloperidol and droperidol and related drugs can cause Parkinsonism by antagonizing the dopamine receptor. Other drugs that should not be given to patients with Parkinson's disease include metoclopramide or Reglan and promethazine or Phenergan. Those are 2 drugs that we see used a lot for nausea, and we'll speak about them in a few more weeks. But they can also interfere with dopamine activity, and they're pretty contraindicated in patients who have Parkinson's disease. What other drugs can be given to patients who have Parkinson's disease? This is a list you mostly don't really need to memorize, but it's just to round out the discussion. It would make sense that we could give other dopamine agonists, and they exist, drugs like bromocriptine or pergolide. Sometimes these patients will be given anticholinergic drugs like cogentin, which is benztropine. These drugs help to restore the balance between acetylcholine and dopamine, and it helps with their tremor, it helps with their salivation, although not very much with their rigidity. There's an antiviral drug called amantadine, which may also release dopamine. And then way back at the beginning of this lecture, we spoke about selegiline, which is an MAOB inhibitor, and that may also help with Parkinson's disease by increasing dopamine levels. That's all we have to say today about psychiatric and CNS drugs. Please let me know if you have any questions, and we will look forward to seeing you in class.